Hello, my name is Casey, and today I am presenting you a teen pregnancy prevention program based on the theories we've learned throughout this semester. This is just an overview of what we will be going through today, starting with the background on teen pregnancy, my proposed theories, my proposed intervention, the methods to assess the intervention, anticipated challenges, as well as potential solutions, and the conclusions. To begin with, in 2017, the rate of pregnancy among teens ages 15 to 19 years old was about 17.4 per 1,000 females. This rate declined to 16.7 per 1,000 females in 2019. However, among all Western countries, the United States carries the highest teen pregnancy rate within this group. Additionally, there have been racial disparities in teen pregnancies. For example, teen pregnancy rates among Hispanic and African American girls were 2 times higher than the rate for white teens in 2019. And American Indian/Alaska Native teens had the highest rate of pregnancy at 29.2%. Repeat teen pregnancy is especially higher among minorities and low-income communities. Research also shows that teens who identify as bisexual as compared to lesbian or gay have higher rates of sexual behaviors that increase their risk for STIs and other negative sexual health outcomes. According to Healthy People 2030, there is a lack of a formalized sex education among teens and schools, where 15 states do not currently require sex education to be comprehensive or even medically accurate. Adolescent mothers have an increased risk of pregnancy complications and adverse health outcomes, including preeclampsia, eclampsia, maternal anemia, and postpartum depression, as well as adverse neonatal outcomes such as low birth weight, stillborns, and low APGAR scores. Current literature suggests that the social cognitive theory is very effective. These interventions include safer choices, making a difference, making proud choices, and draw the line/respect the line. Safer choices has been demonstrated to have the highest efficacy among over 3,000 teens, especially among high-risk adolescents. This intervention was composed of 5 parts: school organization, curriculum and staff development, peer resources, parent education, and school community linkages. The results of safer choices showed that there was a significantly increased use of condoms and a significantly reduced of the frequency of sex without a condom. This intervention was also shown to be effective regardless of gender, ethnicity, or sexual experiences among teens at baseline. Another commonly used theory was the integrative model of behavioral prediction. This study included a health coaching program among sexually active teens at the Children's Hospital of Philadelphia in 2017, and it demonstrated cost effectiveness and behavioral maintenance of contraceptive methods. However, this study was limited due to a low sample size of 33 teens. Interventions based on the Information Motivation Behavioral Skills, or IMB model, included a text messaging-based prevention program called Girl to Girl among 948 teen girls ages 14 to 18 years old. This study showed that there was a significantly increased use of condoms and other contraceptive methods persisting up to 12 months after the intervention, and the incidence rate of protected sex events was significantly higher for the intervention than the control group 9 months post-intervention. It was also particularly effective in older adolescents and bisexual participants, and there were no significant effects of the intervention on abstinence. Overall, teen pregnancy prevention programs and youth developmental behavioral interventions are suggested by the Department of Health and Human Services. They encourage the use of effective training materials and resources. There is limited data on the efficacy of patient-centered health counseling for contraceptives, such as the health coaching model or approach. So therefore, it is important to continue these comprehensive health programs at a large scale and longitudinal basis. And there is also, however, there is a lack of studies evaluating the cost effectiveness of these curriculum-based programs deployed in schools. Moving on to my proposed theories for intervention. So the goal of any intervention and prevention program is to raise awareness about the benefits of contraceptives and increase contraceptive use. To do this, I propose to use two theories, the social cognitive theory and the information motivation behavioral skills model. As an overview, the social cognitive theory states that learning can occur within a social context, whether that be from modeling behaviors, imitation, observations, reinforcements for that behavior, or addressing cognitions underlying that behavior. The social cognitive theory outlines how to learn new behaviors by building self-efficacy to engage in contraceptive use. Building self-efficacy usually involves enhancing perceptions about individual capabilities and exposing people to successfully performed behaviors. This should be task specific, and it should include very relevant skills to the behavior you're trying to change. Without the proper skills, one may not develop the self-efficacy to engage in behaviors such as contraceptive use. I also propose to use the information, motivation, behavioral skills model. I'll call that IMB here. The basis of this model is that information and motivation must come before behavioral skills. So overall, there are four constructs in this model. One being information, which requires people to have a high degree of knowledge about the health behavior. So within this context, we can use formal sex education curriculums and the act of raising awareness about the risks of teen pregnancy to enhance the information construct. Motivation construct helps address attitudes, including perceived gains and threats and social acceptance or subjective norms. The behavioral skills aspect combines can be combined with the construct of self-efficacy from the social cognitive theory. And finally, behavior is the use of contraceptives in this context. This is just a model of how these constructs are interconnected. You see here that information and motivation contribute to behavioral skills and overall will contribute to behavior. All of them are interconnected together. The IMB also involves three additional phases: elicitation, intervention, and evaluation. Elicitation is the qualitative investigation about the feasibility and acceptability of the intervention. This can be similar to the social and epidemiological assessments from the precede proceed model. This can be in the form of pilot studies as well. The second phase is the actual intervention, which I'll go into here in a few slides. And finally, evaluation is the analysis of your follow-up data for associations between the constructs. So using these constructs for the intervention, the information construct will involve information about the risks of teen pregnancy, contraceptive use, and available resources. This would be a form of passive learning in terms of curriculum. So information can come in the form of approved curriculum material, information from social media campaigns, and voluntary text messaging with interventionists. Motivation construct can be enhanced by discussing the reasons to start birth control and addressing the social acceptance of contraceptive and more interactive text messaging. So this can be seen as a more interactive learning process. The construct of behavioral skills and self-efficacy are combined together, as I've stated. This can come in the form of demonstrating the use of condoms and introducing students to contraceptives that they can actually hold, such as birth control pills, vaginal rings, implants, patches, and IUDs. This can also further improve the information construct. And finally, behavior is the longitudinal self-reported use of contraceptives. And just to add to that, building self-efficacy can be integrated into a curriculum utilizing related interactive activities. Moving on to my proposed intervention. As an overview, my proposed intervention would be a multi-component, multi-site observational design targeting teens ages 14 to 15 years old around the 9th grade. The objectives of this study would be to raise conscious awareness about the risks of teen pregnancy and the benefits of contraceptives and increase the use of contraceptives. My proposed intervention has 4 parts, starting with support from school organization, curriculum development and delivery, social media awareness campaigns, and a voluntary text messaging prevention program. Starting with support from the school organization, this would require support from the school and a special council of or group of teachers, administrators, parents, students, community members, public health experts, and interventionists. This council can help coordinate and approve school-wide curriculum, social media campaigns, and other activities related to the intervention. The curriculum program would provide educators with evidence-based training and technical support to deliver teen pregnancy prevention information and incorporate this curriculum can be incorporated into health education courses already required of high schoolers. The curriculum program would include lessons, interactive activities, teacher and student-led discussions. Skill building interactive activities include demonstrating the use of condoms, exposure to contraceptive devices, and guidance on how to communicate with potential sexual partners. The curriculum could also provide a resource guide on how to access contraceptives, reproductive services, and family planning clinics that must be updated. And the curriculum could also include invited guest speakers from the community or local health department to speak about teen pregnancy prevention and the risks. The third part of this component, the third component of this intervention is the social media campaign, which would include the dissemination of approved relevant information about how to prevent teen pregnancy and preventative skills and guides to reproductive health resources. Of course, this would have to be approved by that special council of administrators, students, teachers, parents, etc., before they make regular posts on official school Instagram and / or Facebook accounts. A study showed that 95% of teenagers have been reported to use social media, so they may be more likely to follow their own school's official accounts for updates. And finally, I would like to include a voluntary text messaging-based program. If students choose to sign up, they will receive daily texts for about 2 months. This would include information about teen pregnancy prevention, reasons to engage in contraceptive use, and links to online resources and videos. There would also be an interactive Q&A session with trained interventionists to provide a more individualized delivery and answer any questions that students may be too shy to ask in class. And finally, because this is voluntary to maintain motivation, this program can include financial or any other tangible incentives that gradually increase over time if students sign up and interact with the text messaging program. To assess my proposed intervention, we will employ the 3 phases of the IMB model, beginning with the elicitation phase. Again, this is similar to the social assessments from the Pre-Seed model. It is to assess the acceptability and feasibility of this type of intervention within the school community. This would include a wide array of data collection techniques, such as surveys and interviews with school administrators, teachers, students, parents, and other community members. And if it is found to be acceptable and feasible, we can move to the intervention phase, which is what I mentioned before. And finally, the evaluation phase would help measure outcomes at baseline and post-intervention. This would assess for any associations between the intervention constructs and the outcomes. The primary outcomes of this study would be the number of times students engaged in condom protective sex and the uptake of any contraceptive devices through self-reported surveys. A potential secondary analysis would be medical chart abstractions to objectively define the rate of teen pregnancy after the intervention. Some challenges I anticipate with this intervention would include the ability to obtain a large multi-school sample size. A potential solution to this would be to reach out to a large number of organizations and schools and perhaps convert some of the curriculum-based interventions to remote platforms so more students can access the information. Another potential challenge would be the potential for low survey response rates and follow-up. This can be resolved through text reminders about completing the surveys, improving access to remote survey links if a student is absent from completing it in person, and / or incentivizing students to actually complete the survey. And lastly, any teen prevention program must account for any subgroup differences. This would include age, race, ethnicity, sexual orientation, and household income. All of these factors have been shown to demonstrate differences in the effectiveness of different types of teen pregnancy preventions. To conclude, adolescent mothers face higher risks of adverse pregnancy outcomes, complications, and adverse neonatal outcomes as a result of teen pregnancy. There is a lack of a formalized, universally and socially acceptable sex education program in many states, and previous studies have shown that effective intervention programs utilize the social cognitive theory and the information motivation behavioral skills model. My proposed intervention leverages the SCT and the IMB model and involves support from the school organization, curriculum development and delivery, a social media awareness campaign, and a voluntary individualized text messaging program. Teen pregnancy prevention programs are likely to require a thorough social and epidemiological assessment to assess for acceptability of a program. Other programs are likely to require multi-component interventions and various delivery methods. For future directions, further studies can investigate the cost effectiveness of curriculum-based interventions that involve financial incentives such as mine. They could also explore the effectiveness of patient-centered counseling approaches and broaden study populations to target high-risk teens from low-income and minority populations to investigate the impact of socioeconomic factors and access to reproductive health services on teen pregnancy from a socio-ecological perspective. Other studies can determine if interventions work better in certain youth populations, and there is a need to conduct more longitudinal studies to determine the maintenance of health behaviors post-interventions and their effects on the rate of teen pregnancy. Thank you for listening.